Good morning, everyone. Welcome to Grand Rounds. Thanks for coming. I'm sure we'll get some more people popping in. Excited today to have our guest speaker, Dr. Shaman, and I will turn it over to Dr. Levin to introduce him.
Thank you, Dr. Thomas. Good morning, everyone. Good morning, Dr. Shaman. Welcome to Grand Rounds. Today, we're joined by Dr. Jeffrey Shaman, who's a professor in the Department of Environmental Health Sciences and director of the Climate and Health Program at Columbia University Mailman School of Public Health, the faculty chair of the Earth Institute at Columbia University, and the senior associate dean for faculty affairs at the Columbia Climate School. He studies the survival, transmission, and ecology of infectious agents, including the effects of meteorological and hydrological conditions on these processes. Work to date has primarily focused on mosquito-borne and respiratory pathogens. He uses mathematical and statistical models to describe, understand, and forecast the transmission dynamics of these disease systems and to investigate the broader effects of climate and weather on human health. Thank you for joining us today, Dr. Shaman.
Thank you, and thank you for the introduction. It's a pleasure to be here. I'm going to just go right into this and start sharing my screen. Make sure everybody else is sufficiently minimized that I can see what I'm actually using and go from there. So I'm going to talk today about some work that we've been doing throughout COVID-19, which has principally been focused on modeling mathematically the disease transmission dynamics, inference of its underlying characteristics, projection of what it will do in the future, and even some counterfactual simulation of control strategies and what might be done to better control it, all at a population scale. So a lot of what I'm going to be talking about implicitly focuses on, or I should say explicitly focuses on, population scale dynamics. There's a whole wealth of modeling that is actually used to look within cells, within hosts and whatnot, and at other scales, but that will be the principal focus here. I'm just going to briefly acknowledge the funders up front. I do this because I forget to do it if I put it at the end. And I also want to acknowledge the many collaborators who've contributed to the research that you're going to see here. I just thought I'd start very briefly with a short overview of what is a model. And a model, it comes in all sorts of shapes and sizes. It's an idealized simplification that represents some process in the real world. There are many forms of them. Mental models we have when we're thinking about how we're going to drive from point A to point B. We often form a mental model of how we're going to get it, and we map it in our head. And it may be very explicit for some people or very fuzzy for others, but it is a representation of what you're going to do in the real world. There are also, of course, computational models, which is what we're going to focus on here, that use either statistical or mathematical processes to represent some sort of system. On the right, you have a schematic of what would be a very complicated model with billions of degrees of freedom of the climate system that take supercomputers to run. But there are also much more simple computational models as well. Any model that we work with really is taking input information, it's processing it according to a set of governing rules, and it's producing an output. Now, in infectious disease, there are also a very large or wide variety of constructs used to model infectious diseases. At population scales, many of them fall into two categories. There's a compartmental model, and you've probably all heard, if you hadn't known already during the pandemic, about an SIR model. In a compartmental model, you take a given population, say New York City, and you divide it into classes of current disease status. In this case, those who are susceptible, S, those who are infected, I, and those who have recovered, R, from the given disease. You then have a set of governing equations that are usually mathematical that describe the transitions between those compartments. You set it up with some initial conditions, and you can evolve it through time. And if it's correctly posed, it can represent actual outbreaks, and it has the self-limiting behavior of a wave of say, COVID-19, as we've seen over the course of the last 2 years. At the other extreme, the other type of models would be individual or agent-based models, in which individual actors are represented within a model construct. This is a highly computational framework, and each of them has their own individual disease status. And based on their interactions, there's some governing set of rules that allows them to pass the pathogen from one person to the other. And when a person's infected, they have a time scale through which they may recover or interact with others during their contagious period, et cetera. So in this instance, you would take the 8.4 million people in New York City and you give them each rules to follow. And you'd assume you know when they go to work, when they go to school, how they're interacting, how transmission actually manifests. You may be noticing that in both extremes, there's a lot of what we would call misspecification. The representation of the real world is off, it's wrong. In a compartmental model, there's this assumption that everybody in New York City, say, is in perfect contact with everyone else. And we know that's not the case. Most of us don't interact with most of the other people in the city. On the other hand, in the agent-based model, there's an assumption that you actually know what people are doing, which is also flawed. So both of them have issues that are problematic. However, they can actually capture gross population scale behaviors that manifest, and they can be used in conjunction with, as I will show you, statistical methods and observations to be constrained to actually represent what goes on in reality in a better fashion. So maybe the last little bit on infectious disease models should be what does an infectious disease model do? Well, typically it's providing very limited context-specific information. They have to be designed to answer specific questions. They can't do everything. And infectious disease models, in my mind, have three principal uses at population scales. One is simulation and inference, and that is it's used to replicate observed processes of disease transmission, observed outcomes, and to estimate the underlying processes of a disease, like what's going on, how long is a person latently infected with COVID, what's the basic reproductive number, what's the effective reproductive number, how many people are actually susceptible to the latest variant coming through. These are all unobserved quantities, which we want to get a handle on if we can, so that we have a sense of how quickly or rapidly a given variant might move through a population and what the risk is. The second thing you do is you use them for forecast. If you have a model that's well constrained, you hope by observations, you can use it to integrate into the future and actually project future outcomes. And the third is counterfactual simulations. If you have a model that you feel represents reality fairly well, it provides an in silico playground for testing alternate control strategies. You can't do this in the real world, but you could say to yourself, all right, well, what happens if we closed schools? Well, what happens if we thin the classes instead? Well, what happens if we stagger terms? How does that contrast with the effects of having a lockdown or asking people to telework or having 50% of the population mask? These are the things that you can actually test and compare in a model framework. And even though it may be biased in some ways, it's something you'd never be able to do in the real world. All right. So with that, I thought I would talk to you about these various principal uses. I'm going to focus on the second one, forecast, first. I'm going to tell you a little bit about some work we did originally on influenza, and you'll see ultimately how the methods that we used here are then translated into simulation and inference and ultimately projection and counterfactual simulation for COVID-19. So what I'm showing you right here is a model that we had built that represented influenza, and it was a humidity force model because there was this hypothesis, and certainly people at Mount Sinai have been looking at this in great detail with some experiments to see how influenza virus survival is modulated by ambient conditions. Now, this model uses specific humidity, which is one form of absolute humidity as a driver. And what we were able to show on the right for 5 states you see there is that simulations with actual observed humidity conditions over a 31-year period as the sole driver of this influenza model were able to represent observed climatologies, if you will, average outbreak conditions over the 31 years in those 5 states. So the red dashed line shows you excess pneumonia and influenza mortality averaged over a 31-year period. It's daily values. And you can see the rise that takes place in the wintertime in late December, peaking in early January or February, and then coming down to low levels in the summertime. The blue line is the best fit model that is humidity forced, and the green lines are 2nd through 10th best fit models. Now, the interesting thing is that the states that you have here have different humidity conditions. They all have the same phase cycle you can see on the left, where they're most humid in the summertime and least humid in the winter. But the range of it and how it manifests differs as you go from desert Arizona to Pacific Northwest Washington to Illinois and then to subtropical Florida. And even though they had differences, the same sets of parameters, the same sets of conditions that represent how the pathogen interacts with humans and how it responds to humidity conditions, we're able to produce these fits that you see there. So what this model showed to us is that we could use humidity conditions as observed to represent an average cycle of influenza at population scale. However, we asked ourselves next, well, could we use those humidity conditions to predict individual outbreaks? And we quickly came to realize the answer was no. And the answer is no for two reasons. Firstly, we don't know what humidity conditions will be in the future, except roughly what they've been over the last 30 years on, say, April 1st. I can tell you what the average condition was there, so I could use that. But the other problem is that seasonal flu dynamics are nonlinear and irregular. And what you're looking at is ILI estimates for New York City for a number of seasonal flus seasons. Ignore the yellow, that's actually the fall wave of the pandemic in 2009. But the other curves are showing you outbreaks in New York City of ILI. And you can see they're highly variable. The timing of the peak changes, the area under the curve changes, the duration of the outbreak changes, and that's because the flu dynamics are nonlinear and they're irregular. And systems like that are notoriously difficult to model or forecast using just a simple mathematical model by itself. However, if that mathematical model is coupled with some other things, you can generate accurate predictions. And the best example of this is numerical weather forecasting. Numerical weather forecasting represents a system, the atmosphere, that is highly nonlinear. As a matter of fact, deterministic chaos was derived from study of the atmosphere and its properties. And yet, even though it's highly nonlinear, we have these forecasts that are generated that at this point are really seamlessly intertwined with our lives. We use them all the time, personally, professionally. Businesses use them all the time. Obviously, the military, governments use them. The number of uses for weather forecasts is astonishing at this point. And this represents 60, 65 years of work using computational methods to generate numerical weather forecasts. So the question we posed is, well, could we take the methods that are used to generate numerical weather predictions, and could we translate it to an infectious disease system, here, influenza? So in order to do that, we actually take those three ingredients. So we're going to take the three ingredients that they used there. The first of the ingredients is an observationally validated model of influenza transmission dynamics. In our case, it's going to be that humidity force model that I just showed you for flu. In the case of weather prediction, it would be a model that represents the dynamics and thermodynamics and radiative processes of the atmosphere. So we're going to have a very different model than what they use in weather for flu, obviously. The second thing you need are observations. Now, for weather prediction, the observations are going to come from satellites, from ocean buoys, from ground-based stations, from balloon soundings, everything that they can use to get their handle on readings of temperature and pressure and rainfall and wind speed and wind direction, etc. For us, it's going to be that plot up there on the right. It's going to be some estimates of ILI or some other reasonable proxy for influenza that we can get in real time. Now, the third method is the kicker. It's called data assimilation methods. And data assimilation methods are Bayesian inference methods that are used to iteratively ingest, if you will, the observations into the model framework and find an optimal solution that best matches the model and observations while accounting for the error in both the model and observations. There are all sorts of methods for them. There are things like particle filters and variational methods and Kalman filters, and they almost all rely on Bayesian inference in order to do this. And what you're trying to do, in some sense, is fit a nonlinear evolving system to a set of observations. And in order to do that, you have to find the underlying parameters and unobserved conditions in the model that best allow you to replicate behavior as it is thus far transpired. All right, so why do we do this? Why do we take a model and the observations and bring them together in some formal way using these data assimilation methods? And the reason is because there's error everywhere. If we leave the model to its own devices, if the true outcome is shown there in black, we might get the model to simulate something that looks like that. To make it look a little bit more epidemiological, if the black is the true outbreak, the model left to its own devices without any information about what's going on in reality might produce an outbreak that looks like the red line. Now, that's a really bad simulation if those are weeks, let's say, on the x-axis. It's particularly bad if you started it on week 15 and made a projection of what's going to happen in the future, and you didn't account for the last 6-7 weeks having this exponential increase in cases, if that's what this plot is representing. So there's errors in the model structure that are hard to deal with, but there's also errors in the model parameters and its initial model state that if we don't deal with them, if we don't use the observations to make a better estimate of what those are, those errors will amplify through time and lead to very bad simulations and ultimately forecasts. So this is the name of the game when you're using this model inference system that combines model observations and these Bayesian inference methods. You want to take the real-time observations and your data assimilation methods, and you recursively and adjust to optimize the mathematical model. It's an inference problem that follows Bayes' formula, and that's one example of it right there in the equation. And the idea is if the data are rich enough for the system in question, the state variables and parameters, the stuff that you don't know, how many people are actually susceptible, how many people are immune to the disease, how long is a person infected for, what's the force of transmission? We don't know any of those, but we're going to try to estimate it on the fly in this dynamical model using the observations and the Bayesian inference. And the thinking is that if you can simulate what's been observed thus far, you have a better chance of projecting what will happen in the future. Now, all these methods use ensemble formulations where you're not just doing one realization of the model, but you're using hundreds of linked simulations to actually communicate with one another and use the information across all those various simulations to get a better understanding of what's happening. So I'm going to jump right in and show you what it looks like when it works well. So this is an example real-time forecast that we generated in late 2012 for Salt Lake City for a measure we call ILI+, which is a measure of influenza activity. The black X's are observations of that ILI+ metric for Salt Lake City that we had in hand. It shows you essentially weeks 40 through 50. 50 is the last one right there on December 15th, 2012. The red X's are observations we did not have in hand because it was the future at the time. And what you're seeing in the magenta line is the mean trajectory of a 200-member ensemble, which are represented by the thin lines. For the training or observed period, they're shown in green, and for the forecast period, they're shown in gray. And what you see of this forecast is that 5 weeks in advance of when the peak occurred, which was the 3rd week of January, where that high red X is, I don't know, I don't think you can see my pointer here, that we're predicting that that's when the peak will take place. You can see that the magenta line peaks there. You can see that the whole ensemble spans the observations, and there are a number of things that it's doing well. It's capturing the general area under the curve, the duration of the outbreak, and the timing of the outbreak. Now that's the left plot. If you look at the right plot, it shows you the same thing, but it's actually just focusing on when the peak is predicted to occur, what week. And the red shows you when the actual peak occurred. The blue dot is the mean prediction of that ensemble. It's where that magenta line is peaking, and that's also right on where it should be. The black vertical line shows you the week the forecast was initiated. And the green bars are a histogram of the distribution of predictions for all those individual gray lines, all right? And you can see how tightly or broadly they are spread around that prediction right now. Now I'm going to step through in a sort of slow brute force movie fashion the predictions that took place going from weeks 47 to about week 8 of the following year. So here we are 3 weeks prior, and you see what the ensemble looks like. If you look to the right, you see there's a broader distribution of predictions. We're now 8 weeks before the actual peak occurred. That's the difference between the black line and the red line. And the blue dot is off. It's predicting it's happening too early. Okay? Now there's a lot of uncertainty because you see a broader distribution in the green bars there. Now, as I step forward, you're going to see that we're going to come to week 50, and that's the first week that it gets it right, but all it's been doing is advancing. But if I go to week 51, it stays there, right? And it's a good forecast because it continues to stay there. And you notice that the width, the distribution, the uncertainty of those predictions has narrowed because these green bars have fixed around a very small period now. And because they have that, that means there's higher confidence in the forecast, there's less uncertainty, and it's more likely or reliable that that prediction is correct. So just going back, you go from here, you see how much broader that green distribution is, and you can see it in the spaghetti of the gray lines. And you go forward and you see how it tightens up, and it stays tight there as we go through, and it maps out the rest of the outbreak. So that's an example of a successful forecast. And of course, as you're doing it in real time, you don't know if it's going to be successful or not. I can certainly show you examples of not successful forecasts. And the aim here is to try to improve them, to make these forecasts more reliable. The same way weather forecasts are sometimes off, and the way they've gotten better over time, we want to do the same thing with infectious disease predictions. So how do we do that? Well, we test all sorts of alternate model forms. We test ways of improving the model optimization, the way we use those Bayesian inference or data assimilation methods. And we look to ways to actually intersect with the forecasts with public health and clinical use, test different observational streams, have spatial models, all sorts of stuff. Now, my group has been doing this type of forecasting for almost 15 years now. We have had a web portal that we had active for flu. It's been quiescent for the last few years because flu activity has been kind of reduced since about March 2020, though we have had some activity this year. It really got squashed, it seemed, during the Omicron outbreak. We also have, let's have it this way. We have also taken the time to build all sorts of different models, try different observations, try different filters. This is an example of a spatially resolved forecast, which was the first one that we did at a time when it was hard to get spatially resolved data. And you can see it was published in 2018. That's just 4 years ago. It was very difficult to get spatially resolved data on influenza. Now you can get it for every state in the country with the exception of Florida, which holds them for some reason. And so this was based off of DOD. We built a spatially explicit model that had commuters and random movement, and it had nighttime and daytime activity. People could live in one state and work in another. And we linked it all up, and we found that it actually generated better forecasts when you had this whole spatially coupled model that accounted for these things, and particularly allowed you to predict the early activity in an outbreak better, because it could see what was going on elsewhere, and it would allow it to align the model for importation and outbreak events from neighboring locations. Other things that we've done, and this is work that was led by a former postdoc of mine, Nick DeFelice, who's at Mount Sinai, was developing a system to try to forecast West Nile virus. And here in the upper row, we're forecasting infectious rates in mosquitoes as trapped by light traps and measured with a PCR assay after you ground up pools of mosquitoes. And on the bottom, it's showing you human cases of West Nile virus. And this is showing it for Suffolk County, New York, out on Long Island. And the predictions aren't that great for the mosquitoes in that it doesn't really get the prediction well until you're at the peak. But it turns out that human cases peak after that. The majority of human spillover infections occur after infection peaks in the mosquito population. And so you get a reasonable prediction of what's going to go on in terms of the number of cases that you might expect from West Nile virus in this county. We've also used it for other systems as well outside of the country. Here's an example that we used projecting Ebola cases in West Africa during the 2014 outbreak. We built a system to do it there. In the case of Ebola, we recognized that there were a lot of behavioral changes going on, and that it was very difficult to know how to make a forecast, given that there were so many changes on the ground, villages going into essentially lockdown. And so what we did in this was we used scenarios instead. We said that these aren't really going to be true forecasts. We're going to optimize our model inference system just as we would for a forecast. But instead of just issuing an integration into future and seeing how well it does, we're going to have three scenarios. One where we do just integrate it into the future, but another one where we improve, the conditions are improved and control is improved such that the force of transmission drops, and another where it degrades and it gets worse. And we use that to try to scope out how things were going forward. And if you look at the bottom row, you could see that for Sierra Leone, our no change scenarios are always, those are the colored lines, they're always rising up above the cases as observed, which are the box and whiskers. Whereas when we look at the improved scenario where we reduce it, it's a little more in line of the trajectory, maybe a little bit low. And it indicates that there was some behavioral change going on that was controlling things. And this is important for ultimately what we did with COVID. So as I said, there are multiple uses for models. It's not just forecasting. There's also this idea of simulation where you represent the model, and that simulation is going to look just like what you're seeing in these plots here, where you see how the magenta line is simulating the black dots as they've gone along. And that simulation process allows for this inference of the underlying conditions. It's so integral for the forecast, but we can actually just look at that itself. We don't have to make a forecast. We can say, well, what is the force of transmission? What is the mean infectious period? How many people remain susceptible in the population? This is an example where we applied this in space and time here in West Africa during the Ebola outbreak. Another example that we've used, and this is actually using an agent-based model, is where we've applied this to the transmission of MRSA and colonization with MRSA in a hospital system in Sweden. Now, given that we have this sort of simulation inference, I want to tell you a little bit about a project that we did that was not mathematical, that was actually a sampling project that we conducted in northern Manhattan that was called the Biome of Manhattan. This was conducted before the pandemic from October 2016 to April 2018. One of the arms of this, it had a couple of aims, but one of the arms involved the setting up of a cohort that ultimately had over 200 individuals. They were from daycares, they were toddlers and their parents. There was a high school students and teachers. There were ED workers, mostly up at New York Presbyterian, as well as people who worked at the Columbia University Medical Center. And among these cohort, what they asked them to do was to give us a daily report of symptoms. They would just enter it over their phone directly into an electronic database. And on a Likert scale, none, mild, moderate, severe, they would tell us how they felt with respect to 9 symptoms, runny nose, cough, sore throat, chills. They would rank it on that scale. They would also tell us on a daily basis if they had stayed home from work or school because of their respiratory symptoms, if they had taken medicine, or if they'd gone to see a doctor. So we have this rich record of symptomology and behavior in response to respiratory symptoms. And in addition, once a week, regardless of how they felt, we would swab these individuals. We'd take a nasopharyngeal swab, we could take it back to the lab and assay it for 18 different common respiratory pathogens. Now, I've grouped all the influenzas, RSVs, parainfluenzas, et cetera, together, and you're just seeing them in overall groupings here. And what you're seeing in the first column here are episodes. And we define an episode on the bottom, you'll see, as a group of consecutive weekly specimens from a given individual that were positive for the same virus. We did allow 1 week gap to account for false negatives or temporary low shedding. And what you can see is that, over the course of this 19 months of sampling, we captured 32 episodes of influenza infection, 275 of human rhinovirus, 137 of the coronaviruses, the 4 different coronaviruses, OC43, et cetera. And what we also found is what fraction of those actually went to seek medical attention. MA is medical attention. You see the numbers in the second column, and then PMA given VI is the probability of seeking medical attention given infection with virus I. And in that case, it's just the MA column divided by the episodes column. And what you can see there is those numbers are pretty low. As a matter of fact, the highest one is influenza, and less than a quarter of the people who had influenza went to see a doctor and sought clinical care because of their symptoms. When you get down to the coronaviruses, it's 4% of them. 1 in 25 persons actually went to see a doctor because of symptoms that manifest during their coronavirus infection. So what did this tell us? Well, it told us that the majority of infections are going to be undocumented. If you do not go to see a doctor, you are not going to be captured by standard passive surveillance that we have, right? Active surveillance, such as this project, can capture it, but passive surveillance would not. In other words, people are doing what most people did before the pandemic whenever they had a sniffle or a sore throat, which is absolutely nothing. They still went to work. They still went to school, they still went shopping, they still went on vacation, they still took business trips, and they ported their viruses around them with them because a lot of them manifest with mild symptoms or no symptoms at all, and we could see that from the symptomological data, and they brought it around with them. They took it to new communities, they took it to new restaurants and places and shopping centers and locations and onto airplanes. They helped take these viruses around. And so what it taught us looking at this is that the reason that common respiratory viruses are common is because they have this property that lots of people don't get sick enough to stay home. And there are lots of infections that are going to be undocumented simply because the symptomology is not severe enough for people to actually go do anything about it. So when we saw the emergence of COVID in early January 2020, when we heard about it, I should say, and then we started to see from the data coming out of China, the rapid movement of cases from the epicenter in Wuhan throughout China, and then the way it was hopping on airplanes and going to Thailand and South Korea and Japan and the US, our immediate thinking was that this is behaving like a common respiratory virus. People must be walking around with this and not aware they're having it, shedding it either asymptomatically, paucisymptomatically, or pre-symptomatically, and sharing it with other people. And that this virus has the property that allows common respiratory viruses to be common. So what we did is we set up a model to try to quantify this. What we built is a model that's similar to that spatial model of flu I showed you. And instead of representing 35 of the 50 states in the US and influenza, we're going to represent 375 cities in China. We're going to allow travel between those cities using 10-cent travel records from the Chunyun Spring Festival from prior years. So we're looking at a period that's January 10th to 23rd, and I'll tell you why in just a moment. So 10-cent is a location-based service that's in a lot of mobile phone apps in China. It's associated with QQ and WeChat, that they have the big chatting apps in China. So 800, 900 million people have it on their phones, and it provides a very good record of what's going on with movement between cities on a day-to-day basis. And we're going to take this metapopulation model, which is shown in those equations there, and we're going to couple it with those data assimilation methods I told you about. And we're going to use daily observations from each of those 375 cities and ingest it into the model and try to optimize it to simulate a 14-day period and infer a number of critical parameters within this model that are going to tell us how contagious this virus is, how many undocumented infections there are, and how contagious those undocumented infections are relative to those that are documented. And we're going to do this for a simple 14-day period, very short period. And the reason we do this is that prior to January 10th, there's not enough observations for the model to really work with. There's not much there. And on January 23rd, that's the date they imposed lockdown in Wuhan. And within just a couple of days, they'd spread it to 75% of China. So what we're looking at is the period prior to lockdown, when the Chinese population is really interacting and moving as they traditionally would during this time period, during this spring festival. All right. Now, in the model, we're separately representing documented and undocumented infections. And each of those groups has a separate contagiousness, right? Now, whenever we have a system like this, and I didn't get into the details of it, one of the most important things that we have to establish is whether the system is what is called identifiable, whether all those unobserved parameters and state variables I talked about actually can be estimated given the limited observations. In this case, all we are observing are documented cases. Is that enough in this framework to allow us to estimate the reproductive number or the average duration of latency or the fraction of infections that are actually documented? Those are what those various parameters on the left 6 plots are. The right one is the reproduction number, which is actually a hyperparameter that you actually build out of 4 of these parameters here. And what you're seeing in this is that what we would do is we would take the model and we would give it some parameters and run it stochastically to produce an outbreak for 14 days. We then take that data and just using the observed cases from the model in a stochastic simulation, we'd feed it into the Model-Inference system and see if it could reconstitute or correctly estimate the parameters that we had used to generate the outbreak in the first place. Now, if it can do that, that is a synthetic test showing that the observations are rich enough to support parameter inference for this system. And what you're seeing here is evidence that that is the case. It's one example. We did it many, many times. We had to convince ourselves, then we had to convince the reviewers, et cetera, et cetera. But this shows you one example of it where the blue is a posterior distribution for those 6 parameters, and the red is the truth. That is the target. And what you're seeing is in all instances that the posterior distribution of the blue is spanning the actual truth. And so what we had then was an identifiable system. And we could take that system and we could actually apply it to the actual data. And when we did that, we get this table that you see here on the left. And the things that I want you to focus on are the two parameters, alpha and mu. Alpha is the ascertainment or reporting rate. And you can see our estimate is 0.14, indicating that we're estimating that during this 14-day period, only 14% of infections were documented in China, 1 in 7. That means 6 in 7, about 86%, are undocumented infections. The second parameter I want you to pay attention to is mu, which is the relative transmission rate of the undocumented infections. And that means that it is 0.55, and it means that roughly it means that for the undocumented infections per person, they are on average about half as contagious as the documented infections. We also got a reproductive number, which was in line with other estimates at the time of 2.38. But what we can see from this is an estimate that says there are a lot of undocumented infections and that these people are contagious, though maybe not as much as the people who are documented and presumably on average have more severe symptomology. Now, once we have that in the parameter estimate, we have a stochastic model. We're going to take those parameter estimates and we're going to put them in the model and see whether or not it actually is able to make the outbreak as observed. And what you're seeing that is here. You're seeing national daily cases over that 14-day period. You see it for Wuhan City over the 14-day period. You see it for the Hubei province, which is where Wuhan lives. And you're also seeing on the lower right the number of cities that had 10 or more cases on a given day. And you can see the X's show you the observations. The box and whiskers show you 100 simulations and the distribution we get there. And you can see that these simulations with the estimated parameters are capturing the outbreak. So what else can we do with this? Well, we can do an actual counterfactual simulation. We said to ourselves, well, we have this estimate that the undocumented infections are roughly half as contagious per person as the documented. It's a model system. Let's make them not contagious at all. What would happen to the outbreak if that were the case? We did that by simply setting that mu parameter to 0. And when we do that, we go from the red distribution, which again shows you national Wuhan and daily cases in the number of cities with 10 or more infections. And if you shut off the transmissibility or the contagiousness of the undocumented infections, you see that the outbreak fizzles comparatively. It doesn't spread nearly as far, as fast, and there aren't nearly as many cases. And that without transmission from the undocumented cases, confirmed cases decrease about 80%. So what it meant was that the lion's share of transmission was happening from these undocumented infections. So what do we conclude from this first study that we did in January 2020? Unlike SARS-1, there are many undocumented SARS-CoV-2 infections, and this includes paucisymptomatic and asymptomatic infections most likely. The undocumented infections are responsible for the majority of transmission. I didn't talk about this, but there was evidence of pre-symptomatic shedding among the confirmed cases as well that we were able to infer, and that the epidemiological characteristics of this virus were consistent with common respiratory viruses, meaning really that it had characteristics that were not going to allow it to be contained, and that this was going to become a pandemic. Now, in the US, we had this in 2020 in terms of the number of cases, this period of rapid exponential growth that started right at the end of February. And so we said at that point, well, we need to actually apply this model system to the US as well. And we could get travel data, inter-county travel data from the Census Bureau, and ultimately then get all sorts of mobile phone proxy data to adjust this going forward. And we built a county scale for all 3,142 counties in the United States model, metapopulation model of COVID-19. We applied the same methods, the same data assimilation, observations of cases from each county on each day, and we applied it to produce estimates for the US through March 13th, 2020. And what you can see here, if you look at alpha, instead of being 0.14, it's 0.08. And that means that we're estimating instead of 1 in 7 infections being documented, about 1 in 12, 1 in 13. Not inconsistent with the lack of testing capacity that existed in the US at that time, and not surprising that it would be lower. At the same time, the relative transmission rate was slightly higher, going from 0.55 to 0.64, and you can see the credible intervals of that estimate right there. It's a little bit higher, which also might not be surprising given that some of the more severely infected were not being documented as having COVID-19, probably misdiagnosed, not tested, not known. Now, once we had that system in place, we could start to do lots of things with it. We could change some of its features. We could make it more complex. So instead of just assimilating cases, we started to assimilate and use observations of both cases and deaths in the model. We could allow certain parameters to vary through time and in space from county to county. And specifically, we're allowing beta, which is the contact rate, and one of the primary drivers of the reproduction number and the force of transmission, to vary. And we're allowing alpha, the ascertainment rate, or what's the fraction of cases of infections that are documented and reported, to change in both space and time. When we do that, we can conduct inferences, and here's a use of that model for the majority of the first spring wave. And you can see the fit it has for national cases and deaths in the first row, and then New York metropolitan area cases and deaths in the second row. And you can see estimations of the effective reproduction number, that force of transmission, through time in metropolitan areas, 6 of them right there. So we're able to use it in an inference capacity to get an understanding of how well we're able to reduce the transmissibility of this virus through lockdowns, distancing, et cetera, though masking wasn't really in play at that time because of unfortunate mixed signaling. Now, one of the other things I told you about that we can use infectious disease models for are counterfactual simulations of alternate outcomes, controls, interventions, strategies. And here's one that we did in that early spring, where we said, okay, we can make this estimate for each county of the reproductive number, and it's going to reflect the control that's going on as well as the basic virus dynamics. In other words, this reproduction number is affected by the fact whether or not people are actually going to work, or if they're in lockdown. Those things are going to limit person-to-person contact, and that's going to be captured in the estimate of this reproduction number. Because people aren't interacting as much, the virus doesn't have as many opportunities to transmit. And this is a time series that not only reflects innate viral properties, but also social and policy-driven responses to the pandemic. And so we could ask ourselves, well, what if those processes that took place, because we have a daily record for each county in the US of what that reproductive number is and what those parameters were, what if that were mapped back just 1 week or 2 weeks, representing control as it had manifest, exactly as it manifest, just taking place a little bit earlier. And what we could see from that is that if you controlled things just 1 week earlier, and that's the top row, showing you national cases and deaths, and then New York metro area cases and deaths. And the X's are the observations from each of those. And the gray line is showing you the change in the model estimate of what would have happened. Before, remember, it was a nice fitting where it captured all those X's within the mean and the bounds of the estimate. Now you can see it's skewed lower, and it's suggesting that there would have been a 50% reduction of cases and an even greater reduction in deaths if we had gotten a handle on this just 1 week earlier. If it was 2 weeks earlier, it's over a 90% reduction in cases and deaths. And what this highlights is not that, not to point fingers at anyone, because this is both a political and an individual behavior and convincing that needed to go on. But what it's showing that is this is an exponential growth process. And the earlier you act on it, even in the ways that we had acted, if we'd just done exactly what we had done, but 1 week earlier, we would have been in a much better state of control, at least for that limited duration of time, as long as we were able to maintain those responses. Something else that we've done further inference of characteristics through time. This is showing you that ascertainment rate estimated for the months of 2020 for national in New York, and you can also see some other metropolitan areas there. On the upper left, you can see the fitting. Again, this is for daily cases of the model through all of 2020 nationally and for the New York metropolitan area. And you can see the ascertainment rate rose over time. It went from that low level in March to up to higher levels, where you're getting about a quarter of all infections documented was our estimate. It's actually interesting because it then rose again. Instead of a quarter, it went down to about 18%. Much of that might be driven by home testing and the fact that people aren't relying on PCR quite as much anymore. Here's an estimate showing you the estimation of the susceptibility of the population. Now that is very conflated and hard to get a handle on now, but this is for 2020, when we were really just dealing with the wild type here in the US. And we were thinking about this as sort of not necessarily one and done, not that people couldn't be reinfected, but what was the susceptibility of the population regardless to this one variant that we have been dealing with thus far? And you can see that there are differences in the way things decreased. You can see the early drop in New York. You can see the large late drop in Los Angeles when they were having this massive wave there. Now, we've been doing stuff ongoing since then. This is some projections that we ran. They were picked up on the New York Times. Shows you a projection for the month of January, the total number of cases that we would see nationally during the Omicron wave just a couple months ago. And it was actually pretty accurate. You can see the projections shown there as on the right for 3 different scenarios that we used, and the circles show the actual outbreak nationally, and you can see how our mean lines actually captured it quite well in this. So this is something that we've been generating on a weekly basis throughout the whole course of this pandemic. Another counterfactual simulation that we did in 2021. This was also in the New York Times, and their graphics are a heck of a lot better than ours, so I use them. And this just shows what would be the effect if restrictions had been lifted in February 2021 as the vaccine rollout was starting. And the need to keep people using masks, trying to limit their contact with persons, limit mass gatherings in order to get people vaccinated so that they got the vaccine before they got the virus. And then if people started to lift restrictions prematurely before people had the vaccine, because vaccine rollout took some time, as we all know, that there would be real repercussions in terms of additional infections, cases, hospitalizations, and deaths. So I will stop here and just give you a few concluding points. And one is that modeling during the COVID-19 pandemic has certainly been elevated in its provenance. We hear about it a lot from the very beginning. You would hear about modeling and studies, including from my own group. Whenever they said Columbia University modeling, whenever Cuomo or Trump said that, they were talking about our model. It's been used to support policy, projection, and response to COVID-19. I would have to say that success has been mixed. There are bad models out there. There are bad forecasts. There are bad projections, and there's improper use of it. And going forward, I think it's very important that we really work to QC this type of work and make sure that there are institutions and places in place that are recognized as the go-to places for modeling expertise. So the CDC, having established recently a Center for Forecasting and Outbreak Analytics, I think is a very important step forward. It's kind of like establishing a national weather service, but for infectious diseases, it provides a reliable authority and clearinghouse for generating, archiving, and managing the types of analytic use of modelings, projections, counterfactual simulations, et cetera. I also think it's important that clinicians and public health officials with modelers expand their communication with one another. That kind of dialogue is really important because it's going to improve the interpretation and use of the model outputs. It's going to better direct the questions that modelers address so they don't go off in left field and ask something that's really not appropriate, maybe. And it's going to ultimately improve the model quality. So I will stop there, and I'd be happy to take any questions that you have.
Thank you, Dr. Shaman. That was excellent. I'm still in shock looking at your equations, though, I have to tell you. They're pretty
Try to limit the number because it's
pretty impressive. So we do have, we use the chat, Dr. Shaman, for this, and there are a couple questions already. Let me just get back to it. So one was, assuming you have the data, what is the value of using a model developed in another country where a new variant has appeared? He's given the example of Neil Ferguson's group at the Imperial College of London, and applying it to the US.
Well, it's not so much that you need the model from Imperial, and Imperial has done simulations of the US. We, for instance, my group, we have done something very much along the lines of what I believe the questioner is asking in South Africa, in the UK, in India, and Brazil, at the emergence of alpha, beta, delta, gamma, and Omicron. We've done South Africa twice. That's why they're 5. In which we're actually trying to estimate what is the change in the transmissibility of the variant and how much immune escape is there? What fraction of the population that we thought was at least temporarily immune from infection to the circulating strain is now susceptible to the new one. So in particular, for instance, we did this recently for South Africa back in December, looking at the Omicron outbreak. And what we could see and what we were trying to disentangle with this was what fraction of this aggressiveness of Omicron is due to intrinsic elevation of its transmissibility, perhaps because it's setting up shop in the upper respiratory tract, running a higher viral titer faster and shedding faster, squeezing the latency period. And what fraction is because the people who were, because of vaccination and recent Delta infection, immune to Delta were now actually still susceptible to Omicron. So how much immune evasion is it comparatively? And what we tried to do with this system was actually disentangle them. So yes, the type of thing that Ferguson's group does, that kind of model, it can be brought and it can be transported, but it always is the instance that model has to be situated to ask the specific questions. And the idea that you can use it incredibly modularly, willy-nilly, without quality control can lead to the slop. So you have to be careful that the model is used correctly. So the model that we use to do that kind of estimation and attempt to disentangle increase changes in transmissibility versus immune escape is a different model than the one I just presented you. So we built a different model system that we can apply, and we've applied to India and Brazil and South Africa and the UK to look at those select situations when that's happening. So it's always important that even though I sort of relied on one modeling tool here for the COVID thing, we've actually built many different models because sometimes the questions we want to ask, one model's not really appropriately equipped to answer it. We have to build a different one that will be able to.
Gotcha. Another question. Given the advantages that asymptomatic viruses have in spread and the rate of mutation of a virus, can your models help to predict the evolution of COVID towards lesser pathogenicity?
Well, I think the answer is yes. You can certainly couple a model with evolutionary processes, and you can certainly see how those two are represented. So in other words, not just represent cases and transmission dynamics, but also selective pressures. And so mathematical modeling is used to study at population scale these kinds of evolutionary processes. And there are groups, my group has not done this yet. We're thinking about it, but I don't know if we will, where you actually couple both together to try to understand the processes that may be at play that allow a virus to become more or less transmissible or change its properties in one way or another. Though I have to say, I do not see any good evolutionary argument that would suggest that COVID should be selected towards lesser pathogenicity. It doesn't kill enough of its population. Unfortunately, it's a crude way of saying it. It's fortunate that it doesn't do that, but the mortality rate isn't high enough, and there's too much pre-symptomatic shedding of people who ultimately die for me to see a selective pressure that would allow this virus or move this virus intrinsically towards a milder state. The only way I could see this happening is if there's some linkage between greater transmissibility and less pathogenicity. Now, we could argue that maybe Omicron represents that because, again, it's more transmissible, maybe because it infects the upper respiratory tract and it's less pathogenic, maybe because it affects the upper respiratory tract. However, I do not think that stops us from having a Delta-like radical variant come out in a couple months that's highly immune erosive relative to Omicron, that is not as transmissible and is a greater propensity to infect the lower respiratory tract. And it will take off because it's still going to have, like Delta, a reproduction number of 6. It's still amply able to run through a population very quickly and be more pathogenic. So I don't buy the argument that this thing is going to move towards a intrinsically less pathogenic form. Now, that doesn't mean that there won't be partial protection because of vaccination, prior exposure, and all those other things, and plus all the therapeutics that are coming out that are going to lower mortality rates. But intrinsically, I don't see the virus moving this way unless we're incredibly lucky because of some linkage to transmissibility.
There's a question around, do you have data for children of various ages to tell whether they should have been in school, masked, et cetera, predicting hospitalizations or deaths?
Well, that's actually very hard to come by. Some of the microscale processes have been really, really hard to come by. There have been some very interesting studies done during the course of this pandemic to try to actually suss out what's going on, for instance, with masking. And, how do we actually measure how many people are masking? There have been studies that send students out into the field to just observe people. And, go out and get a cadre of students over time to observe, and how many observations can you do? And are people wearing it correctly? What type of mask is it? All these microscale processes ultimately are really very important. So it's a challenge, but it's something that we do need to start to address. So I think that the data on that, at least I haven't seen good data on that, though I know of some people who are trying to work up projects to specifically look at control in school systems and how masking and other interventions might be more optimally used. And then that could inform modeling to predict hospitalizations and deaths among children and spread to the broader community.
Great. Any other last minute questions? If not, I want to thank you, Dr. Shaman. This was really excellent. As you know, we have a lot of great research going on here in the virology of the viruses, but it was really nice to have your, sort of macroscopic, sort of modeling perspective. I really appreciate you coming for the day. So on behalf of the department, thank you very much.
Oh, you're most welcome. Everybody take care. Bye-bye.
Thanks, everyone. Have a nice day, everybody.